All right, perfect. Great. So welcome everyone, and thanks for those who are on time and here for the annual vascular um, program for our medical students in the Midwest region. We have a really great faculty panel tonight, and this is our 8th annual year doing it. I think before we start off, something that I love to go over is that old adages can be true. Here's a picture of some coal miners, and they are just, as you can tell, happy as can be. The only whites on them are the whites of their teeth. They've done 108 yards in 4.5 days. And that's one of the things that I think we see in a lot of the folks that apply to vascular is they love to do very meaningful, challenging work. Vascular trainees are some of the smartest medical students we see come across our surgical service, innovative, really good doctors, and dedicated to high technical ability. The old sayings of only do surgery if there's nothing else you want to do speaks volumes about the type of folks that we look for in vascular, because there is time for kids, there is time for spouses and family and hobbies, but you really have to love it because you take care of some sick people, people in great need, traumas that have significant injuries, complex disease processes. And good mentors will always be there to shepherd you through and help you complete the training. And hopefully that's the start for tonight. You have to think at the end of the day, as far as surgeons, which we all are who are on the faculty panel, to start, what separates us from the rest of the world in surgery and even in other parts of medicine. And this is a slide I've used for a couple of years because I love it. This is the difference between the rest of the world and you. Anybody else walks into an operating room and tries to watch an operation or assist with an operation, and they end up like the sad gentleman on the left. If you pursue these fields that you care so much and have so much passion about, you end up like our senior resident there on the right, doing a posterior popliteal vein actually resection that we were doing. And there's really a very beautiful path that follows these things in surgery that leads into vascular surgery for those who are passionate about it and have the perseverance to keep with it. So surgery, and certainly vascular surgery, really is like entering the magical world of Oz, where you have to wear your emerald glasses throughout. Your MD is your passport. The sterile field is your learning environment. And hopefully that journey starts tonight for folks such as our faculty, who can mentor you through the process of learning more about vascular surgery and all that it entails, and some of the individuals that we're looking for. So first of all, like all great accomplishments in life, is most of us that have significant things under our belt and significant accomplishments had it through mentorship at one time or another. Finding your mentors, helping guide you, because they really won't find you. You need to look for them. Looking for educators, looking for national leaders, innovators. Here's all the things that mentorship does for our specialty. And then young faculty that have the time and the project needs and research needs to start looking for medical students to help with projects, to scrub in on cases, to shadow them for a day. People that inspire and challenge you, and hopefully some of the folks on our panel tonight. And at the end of this, as you get done with the talk with tonight, hopefully these relationships continue, and you can reward your mentors with your achievements, because no great mentors do it for a place on their resume or their CV, or because of departmental bonuses or checklists that we all keep. It's really the success that they look for is rooted in yours, and it follows the path of this quote from Albert Schweitzer. So here's what tonight's schedule looks like. We have a really great faculty panel with Dr. Wong, Dr. Coleman, Dr. Speds, Dr. Rouse, followed by a short Q&A and panel discussion at the end. The topics include what exactly is vascular surgery for those of you who may be deciding between interventional cardiology or interventional radiology or trauma, hepatobiliary. There are a lot of traits that are shared throughout different specialties, but vascular is certainly its own standalone. How to make an impression on your vascular surgery rotation, what vascular training path is right for me, and then how to find your mentor. Right after this, we'll have our residency fair at 6 p.m. and you can see the institutions that will be present for that. And just to put a little bit of a flyer out there that our annual meeting for Midwest Vascular is going to be in Grand Rapids this year from September 15th to September 17th. We will have a dedicated skills sessions for medical students there, and obviously lots of opportunities for mentoring and networking through that meeting as well too. So hopefully an extension from what we're doing here tonight. So before we start this process, this is a slide I show to all of our incoming interns as I'm taking them through their curriculum, is be open to the experience. You really have to be open to failures and challenges and things like that to do well in this specialty. And so please use the chat box tonight, ask questions, and get your questions answered so that you know more about the specialty and whether it's a right fit for you. And next, like the opportunities tonight, but also on service, find the time to really discover the quality of life and lifestyle, because all specialties have different mentalities, and vascular has a very distinct one. Same could be said about those in cardiac surgery, transplant, and other really high performing surgical domains. So without much further ado, enjoy the Emerald City tonight. All of our faculty panel and the residency fair to follow. Surgery should really be a magical part of your life if you're thinking about it, and something that you can't live without. So thank you, and I'll turn it over to our first presenter.
Our first presenter is Dr. Wong from Case Western Reserve University in Cleveland, Ohio. Dr. Wong, looks like she's getting her slides up.
Okay, thank you very much. Everybody, can you guys see that? Am I sharing appropriately? Good, all right, thank you. Welcome everyone. My name is Jeannie Wong and I'm the program director for the residency and fellowship training programs at University Hospitals Cleveland Medical Center associated with Case Western Reserve University. We're in Cleveland, Ohio. And I'm pleased that you're here tonight to learn a little bit more about vascular surgery. So we'll go on with what exactly is vascular surgery. So my biggest disclosure, of course, is that I am a vascular surgeon, but in the spirit of full transparency, I wasn't always one. So I'm hoping we can show you a little bit tonight about what we treat, what we do, how we do it, why we do it, and importantly, help you decide whether this is something that you should do as well. The vascular surgeons treat diseases of the vessels, and the vessels in the body include the arteries, the veins, and the lymphatics. And we're pretty much concerned with vessels of the body everywhere outside of the mediastinum and the skull, which are typically dealt with more specialized surgical specialties such as cardiology, cardiothoracic surgery, or interventional neurology, neurosurgery. Principally, our problems come when the vessels malfunction, and this is really two flavors. There's either too much bleeding or there's not enough blood, and the consequences that come thereof. Common vascular conditions you may have heard of that we treat are a lot of occlusive disease. This is principally atherosclerotic disease that causes narrowing or blockages in the arteries, leading to not enough blood flow to the end organs or ischemia. Some of the procedures we do for that are both open, like carotid endarterectomy and arterial bypass, but also interventional or percutaneous, such as using balloon angioplasty and stenting. We also spend a lot of time with aneurysm disease, which is caused by focal enlargement of parts of the arteries that, if gone too far, can lead to rupture and death of the patient. You may have heard of abdominal aortic aneurysms, or AAAs, and we can repair those either by open or endovascular means. We also treat diseases of the veins, vein disease that leads to thrombosis, such as deep venous thrombosis or blood clots, as well as the chronic sequelae of venous insufficiency. And there are several different techniques that are used to treat those disease processes. We're also involved with patients who have suffered from trauma, whether iatrogenic or accidental, when that involves the blood vessels. And we are also the type of surgeons who take care of patients who need access to their bloodstream, whether it's percutaneous access for catheters or whether they need chronic access, such as for hemodialysis. So what types of activities do vascular surgeons do? Well, as you heard Dr. Malinowski say, we are first and foremost surgeons, which is why a large part of the training in whatever pathway you take to become a vascular surgeon involves how to operate, learning how to operate, and how to take care of the complications of surgery. There are many other aspects of surgical training that we use every day in our practice, such as the principles of resuscitation, critical care, and wound management. But we're also trained in using non-open surgical or percutaneous techniques to provide therapy in the vascular system that is remote from the point of entry into the vascular system, such as shown here on the lower right, where we can place a stent graft in the thoracic aorta through a small incision or a puncture in the groin artery. That would be one example of that. And there's times when we use both of these together in a hybrid procedure. But we're also trained in the comprehensive medical therapy and follow-up with patients with vascular disease. And this doesn't involve any type of surgery or procedure at all, where we may prescribe medications or physical therapy to help patients improve from their problems and their symptoms, provide wound care in the office, and offer surveillance of their vascular disease or long-term follow-up. You'll pretty much find vascular surgeons in every type of practice and employment model that's out there. We're also located in urban, suburban, and rural settings throughout the country. There's really no one place in the country that you have to be or that you need to see yourself in order to practice vascular surgery. There's a great variety in the timing of the procedures we do as well. This is not a purely elective specialty, although we do have many procedures that are planned well in advance on patients who come in from home to have those done. Some of the procedures we do are urgent for problems that are getting worse more rapidly, which need rapid intervention, or a patient will suffer worse consequences of the disease. And there are some conditions that are truly emergent, meaning they need attention now, or the patient will suffer serious loss of function, loss of life, or loss of limb. And vascular surgeons are also very important and valuable to the hospital and the hospital system, to other services within the hospital, as we provide assistance and sometimes rescue for procedures that are going on in and around major vascular structures in the body. So really, vascular surgeons help all these other types of surgical services perform the types of procedures they need, and sometimes get them out of trouble when that is needed. So why do we do this? Well, I think a lot of vascular surgeons would tell you we like the variety. There's an extreme variety in the anatomy. You could be working in the arm one case, in the next case in the carotid artery, in the next case doing a femdistal bypass in the leg. You're all over the body. The variety in the disease processes is not the same old every day. The various techniques we can use, and also the urgency. As Dr. Malinowski also mentioned, we take care of some really challenging, older, sicker, and fragile patients who have some really serious problems that they're facing. These procedures can be long or complex, and the complications can be devastating. For these reasons, technical precision is really critical. And I'll say that most vascular surgeons probably see this as a challenge rather than a barrier or reason that they would shy away from the specialty and not want to do it. I would say that one of the best parts of our specialty is that it is rewarding. We really can make a difference in patients' lives. We save lives and limbs every single day. We preserve function and our patients' quality of life, and that's really important to folks. We also develop very long-term patient care relationships, I would say, that rival almost any medical specialty, and is certainly longer lasting than most of the patient care relationships in other surgical specialties. So if you really value those long-term relationships with your patients, the ability to see patients get better, do better, and help them stay better, vascular surgery might be a good specialty for you in surgery. Most importantly, we have a strong need for vascular surgeons. Given the aging population and the increasing incidence of chronic diseases that lead to vascular problems, we are facing a situation where we will not have enough vascular surgeons to meet the need in the near future. The vascular surgery jobs are available, and there are opportunities everywhere for vascular surgeons for patient care, involvement in your community, leadership, and also for advocacy for care of our patients. Importantly, I think it's important for you all to know that vascular surgeons are normal, very fun-loving people. We have lives and families and interests outside the hospital. So I would like you to see that part of us, and I hope you see some of that with what you hear and what you hear and see from others tonight. And the reason really why we all do vascular surgery is because we really love what we do. Thanks very much for your attention.
Thank you, Dr. Wong. It looks like Dr. Coleman is next, and she's going to discuss how to make a good impression on your vascular surgery rotation, or any rotation for that matter.
Thank you, Dr. Wong. As always, that was such a nice reminder to hear out loud from you why we do this job and why we love this job. And I'll give you my own disclaimer that I was not a vascular surgeon out the door and was an ER resident before I switched into surgery. I've never looked back. So I've been asked to talk about how to make an impression on a vascular surgery rotation. And I kind of hope to have more of a discussion format. I think it escaped me that this was just going to be broadcasted and we wouldn't be Zooming with candidates. So I look forward to your questions as we move along in the hour, and I'll honestly try to be a little bit brief so we can spend some time getting through your questions. I guess I'd say up front, as I think about this charge in particular, it's such a really interesting time, not just to be a program director or any type of educational program leadership looking really intentionally to bring in the best and the brightest to their training program. But we're all thinking about how to keep our teams kind of as powerful as they can be. And I use that word intentionally because I think everybody's really looking to ensure as we're onboarding talent, we're doing it with some intentionality. And so I do think that the selection process, the recruitment process, all of that now feels different for a lot of reasons, probably in a good way. But your program directors and all of your educational program leaders are feeling a lot of change, and sometimes that makes us all very uncomfortable. And we've also been forced to acclimate, early on in a really reactive way to the COVID-related challenges that have accompanied these recruitment seasons. But now we're in this really fun place where there will be some enduring results of this shift in how we recruit and how we work. And so it's a really cool time, I think, to think more proactively about what our goals and objectives are and how we streamline the process really for all of the stakeholders. And so I guess I look at this differently than I did even a few years back, and we've made some real intentional changes in what our recruitment process looks like. And so I have to assume for all of you that it feels a little bit uncomfortable to be in this space where, for the last couple of years, in-person sub-internships, right, weren't even an opportunity. And now they are coming back. For a while, there were virtual rotations that were possible, and nobody really knew how those were supposed to feel. But in general, I would hope that most of the people on this call are rotating at least with their vascular surgery team locally. And hopefully this year, you're having an opportunity, if you're at that stage of training, to get out there and look at vascular at other sites. And I'll say something that maybe not everybody would agree with, but I actually think it's so important to consider exploring other programs outside of your home program. Because one of the things I love best about vascular surgery is there are usually several ways to treat a problem, and every institution is going to have its way that is perhaps more recognized as, I'll say it's the Michigan way where I'm at right now, and it's not that way everywhere. And the cultures of different programs are going to feel a little different, and everybody has different strengths. And so I think it's really important to see what vascular surgery is like at different programs so that you really feel comfortable that it is, collectively the whole specialty that you are excited and enthusiastic about. So how do you make an impression on a vascular surgery rotation? I think some of these concepts carry over through other stages of your recruitment cycle. And I don't think it's rocket science, because I would just kind of push this back on all of you and say, as candidates, how do you want to have programs make an impression on you, right? We're going to be auditioning each other. And so we're both kind of driving. I warned everybody that we're in the middle of an epic thunderstorm. And if my power goes out, I really apologize. My lights are flickering right now. So I'm thrilled that everybody's here. So welcome to the team and welcome to the family. We are so excited that you're considering vascular surgery as a specialty. You're going to hear from everybody tonight really how much we authentically, truly love our job. It is the best job. And I think there are so many parts of this job that bring people a lot of satisfaction. And what's fun is everybody has different joys and passions within this specialty that span a lot of different spaces. And so you're going to find kind of your niche within vascular surgery. And it's a really exciting time, I think, to do that. But I would just say, are you sure? And this gets back to some of the points that Dr. Wong has already made. Your job moving forward, before you even get to that rotation, is to make sure that you are excited about vascular surgery. And not just the way your resident team made you feel when you rotated on the team, because surgeons are like family and it's really good to be part of a team and you all take care of each other and you do really fun stuff, but really dive into the specialty and use mentors at lots of different levels. And so these are a few of mine. I'll highlight John Rechtenwald, John Eliason, Gib Upchurch, all amazing mentors to me at Michigan, many of whom now are no longer at Michigan, but they were critical people when I was thinking about vascular surgery, and specifically showed me a lot of nuances about the specialty that I may not have otherwise learned had I not really dug in deep. And they were available to me as a general surgery resident who was completely undecided and went out of their way to get me engaged and excited. And that mattered. And what I would charge all of you with are to find your Gib Upchurches and your John Eliasons and your John Rechtenwalds and your Dr. Smeds and your Dr. Wongs and everybody else on this call, because there's a ton of people out there who do want to support you. And you can do this by utilizing the societies that have put these teams together for you. And I think in exploring different mentors and sponsors and just stakeholders within our specialty, you'll have a sense of what we're like and what we are looking for. I'd highlight also that the house officers, the residents and fellows alike across institutions, are just a wealth of information and knowledge and guidance and experience. And so don't be shy in reaching out to them. And this is a picture of Danielle Stutsko when she was a resident at the University of Michigan. She's now the APD at UAB, and you guys will interface with her, but this is her interfacing with undergraduate students for an outreach program. These are the things that allow you to start forging networking relationships. And I think that helps as you consider your rotations and then your future interviews. When you're on your vascular rotation, I've got one slide that's going to go over some of the pearls I think are important, but I did just want to introduce the concept of the extended phenotype of surgeons, and specifically vascular surgeons, both in the community and in the academic setting. And what I mean by this is that we have the capacity to impact our environment, other humans, and culture. And I think that's a really, really important takeaway point as you're exploring entering the specialty and you think about the work you're going to do, not just for our vocation, but our patients in particular. And I think that we are most effective when we empower our collective and diverse strengths. And this bullet point matters because when I am looking for people to recruit, I am looking for people who think differently and bring different skill sets to the table to put together a team that is comprehensively stronger. And so leveraging our uniqueness offers a competitive advantage. And this is important because I don't want people to think when they're interviewing or they're on a rotation that they have to fall into line and fill whatever is that bucket that you think you're supposed to look like or act like or appreciate. My point is that I want, when you are on your rotation and you're interviewing and going through this recruitment season, please be authentically you. And I think there is a classic academics triple threat, but I think it extends now in this kind of new world to intentionally involve a few other pillars that focus on culture and service. And those are really kind of 5 pillars that I, as a program director, care about very much. So when you're rotating with us on service or you're looking at our program for a position, I'm trying to tease out from you things that you have done or things that you are excited about that support these different pillars. There are a lot of opportunities for visiting rotations, I think, nowadays, and I think most programs are back online. And I would say this, when you're on a rotation, either your own home rotation or you're outside of the walls of your home institution, just remember a few pearls. The first is that it's a match, and that means it really goes both ways. And there is something to feeling a connection with a team that you want to join. And you can't really recreate that, I don't think, super easily virtually, but there are a lot of surrogates that you can look for. But this is where doing a rotation, I think, is really helpful, because you can tease out the nitty-gritty of the culture and what the institution values and how people treat each other, how they're accountable to each other, what work feels like when it gets really heavy, where funds go, what programs invest in. And so we're trying to showcase our program for you, and then you are trying to showcase yourself to us. And that's really, really important, because you're either going to do great, you're going to do average, or you're going to sink. And if you bomb it, no one's going to match you at that program. So just remember that when you come for a visit. It's important to do your homework. And so be really, really prepared. That means you should have a sense when you come of who you're going to work with, what their interests are clinically and or academically. If you come to the University of Michigan and you're dumbfounded that we operate at the Children's Hospital, like, that's probably a problem. So think about who you're going to be interfacing with and do a little bit of pre-reading. And that's the same concept that you're going to want to maintain when you're going into an interview and you're thinking about the individuals you'll have conversations with. We've done our homework for you, and we've accepted you to come and rotate for a reason, or come for an interview for a reason. And we're going to have lots of questions for you. And personalizing some questions authentically because you're interested, I think, is really helpful. I think it's important to really work hard. And I say this really intentionally right now because we all work hard. And I think most of us as faculty are working harder than ever in this new environment, with all of the distractions and the challenges that we face operationally to kind of enact patient care and other things. And so one thing I will propose is that sometimes the faculty don't have the same work hours that the house officers have. And there is a really important accountability that I think resonates with most surgeons, that if you operate on a patient and that person has a complication, that you're going to take care of your patient. So the patient always comes first. And in general, the clinical learning environment will support reasonable work hours. And as a student, you're going to have limitations to that. But you should be working smartly in a way that allows you to be present when there is high yield work to be done, that allows you to be part of the care team taking care of patients longitudinally. And then when there is opportunity to fall back, then fall back, but be there when the important stuff is happening. We don't want to come to the OR for a rupture and not have somebody around to help and learn from that experience. And so visibility, I think, really matters. And if you're rotating on the service, find a way to interface with the people that you want to interface with. So generally speaking, there are going to be multiple faculty that you're going to want to try to have some face time with. I think it's really important to be authentic. It is most important to be kind to everybody. That is not just the faculty that you're trying to impress or the residents that you're trying to kind of fit in with, but that means being nice and kind to the OR nurses and to the administrative support and the people who vacuum the floors at night. Just be kind. It is a small community. And be honest. There are a few things that as a program director, I have a kind of a no-go for, and there's a no tolerance for certain types of behaviors that generally involve dishonesty and mistreatment. So just don't go there. That'll get you an immediate kind of not rank. We're not interested. And so I don't actually think it's hard. And if you love what you're doing, all of this should be really natural. And you'll have a rotation that it's, particularly high yield. I'd say to you all that there's a ton of resources out there through not just the APDVS, but through larger national and regional societies like the SDS in the Midwest, lots of podcasts, lots of online content now, and more progressive learning opportunities. So hopefully it's a good time to kind of go through this process. We are super excited to be back in person and hosting students. We are thrilled that you want to be vascular surgeons, and I think all of us collectively on this panel are reflective of most faculty in vascular surgery in that regard. And there are faculty and residents and fellows just anxious and standing by to kind of help you through this process. So make those connections, let us know how we can help. And thanks tonight for tuning in. We're so grateful you're here. Thank you.
Thank you, Dr. Coleman, for kind of giving us those tips and tricks on how to excel on a vascular surgical rotation, especially in how much our world has changed, over the last 2 or 3 years. So, so the next step is kind of how do we get into vascular surgery? What are the different ways of getting into vascular surgery, which Dr. Smeds from St. Louis University's in St. Louis, Missouri, is going to cover.
Thanks. So I'm Matt Smeds. I'll be talking about which vascular surgery training pathway is right for me. Don Coleman went through the ER to get there, but we all find our own routes. So I don't really have any financial disclosures, but I will say that I did a fellowship after general surgery. So maybe that imparts some bias on me towards fellows, but it really doesn't, because I think both routes to get to vascular surgery are right if it's right for you. So the first question you have to ask yourself is, why be a surgeon? This Time article from a few years ago really answered it for me. This is why I became a surgeon, clearly. Surgeons are the most attractive doctors. So obviously I should have become a surgeon. They say that we're practically minded, we possess a high IQ, and we can remain calm in difficult situations, and we're good with our hands. And so if you have all those criteria, maybe you should become a surgeon too. Dr. Wong gave a nice introduction on what vascular surgeons do. This is what my friends think I do, roll around in money. My mom thinks I just treat varicose veins all day long. And what I think I do is sit in front of a computer doing the electronic medical record. But what I really do is treat peripheral blood vessel problems. And so, we treat all sorts of problems with arteries. Dr. Wong talked about that. I'm not going to belabor the point. But what's involved with vascular surgery procedures is a lot different answer than it was 20 years ago. And several of us on this panel have kind of seen a lot of these changes happen in front of our eyes. So things change in medicine. This is a painting that Thomas Eakins painted back in 1875. And this was called the Gross Clinic. And it was basically depicting the emergence of surgery as a healing art. And this was the conservative treatment of osteomyelitis of the leg. And so you can see this picture is vastly different from what we would expect in an operating room. Now, there are some similarities. You got the med student sitting over there taking notes in the corner. You got the anesthesiologist guy up here checking his stock prices and stuff. And so there are a lot of similarities between nowadays, but there is a lot of differences as well. The same guy painted a painting like 15 years later, and you can see there's already dramatic changes here. So now we got the sterility. We actually have an anesthesiologist administering ether, and there's changes just in that 15 years. The same can be said for vascular surgery. So we go from being a standard operating room to having a hybrid operating room where we have the capabilities to do endovascular procedures at the same time as open surgical procedures. And so things clearly have changed within medicine, and they changed within vascular surgery. And likewise, similar to things changing in medicine and vascular surgery, things have changed in the way that we've trained vascular surgeons in the last 20 years. So how do you become a vascular surgeon? There's two ways. You all go to college for 4 years, you all go to medical school for 4 years, and then you can go the traditional route or the 5+2 route, where you do 5 or 6 or 7 years of general surgery residency, and then you do 2 years of vascular surgery, a fellowship. The other route is to do your years of medical school and then go on to integrated vascular surgery residency. The fellowship route is also called the 5+2 program, and you come out of that with board certification in general surgery, as well as board certification in vascular surgery. If you go with a vascular surgery integrated residency route, you only come out with board certification in vascular surgery. So what's the difference between these training models as far as vascular surgery goes? The integrated residents require 18 months of a core general surgery experience. These are rotations on general surgery or general surgery-like rotations. There's 6 months of swing rotations, which might be other months of general surgery. They might be months of vascular. They might be months of vascular important rotations. And then there's 36 months of vascular surgery. These trainees have a yearly in-service examination. They get certified in the RPVI and how to do the vascular lab interpretation. The vascular fellowship, on the other hand, is 24 months of just straight vascular surgery. They also take that same B-site examination that the residents take. Here's just some examples of the rotation schedules that our trainees at SLU have. This is the integrated residence rotation, and what you can see is that we've kind of backloaded the years with vascular surgery, and so the last 2 years are basically the equivalent to the fellowship years that a fellow would undergo. The first 3 years have varying amounts of vascular surgery and general surgery experiences. Our trainees are lucky enough that they have several rotations that they can do vascular experiences on. even though they're quote unquote general surgery. And this is compared to our fellows rotation, which is vascular surgery all the time. So they're just 100% vascular surgery. So there are some differences and there's some similarities, but if you look at the total case numbers, which is what people kind of get concerned about, are they going to get the same operative experience if they do a vascular residence as compared to a vascular fellowship? There is a difference in the total major operations. And so the general surgery trained people will clearly come out with more total major operations because just by definition, they're doing 2 more years of senior level surgical training as general surgery chief residents. However, if you look at the total vascular cases, which is probably the more important number, there's really no difference between integrated vascular residents and the vascular fellows. So they're getting the same number of vascular procedures. Similarly, if you look at the different types of vascular procedure, there's really no difference between the vascular fellows and the vascular residents. So open peripheral obstructive, endovascular peripheral obstructive, open aneurysm, endovascular aneurysm. It's all the same between the vascular residents and the vascular surgery fellows. Now, where does the general surgery beat you? They're doing more biliary, small intestine, large intestine stuff. And I can't tell you the last time I took out somebody's small intestine or large intestine. So frankly, I'm not sure it's really necessary. So what else? Are there any other differences? You know, ability to do research is kind of bantered about by some people. There are several integrated programs. I think Dawn has one that allows this dedicated research time and extra time to devote to other interests other than vascular surgery. General surgeons frequently also offer research time. But it's really not necessary if you're matching into vascular surgery, although if you want to do it, you certainly can. It just kind of extends the time that you're in training. My generalized gestalt is that, these people come out similarly trained. The 4th year 05 integrated resident and the 1st year fellow are pretty similar in my eyes. The fellow tends to have a little bit more surgical swagger than the integrated resident because they've just been around the body a little bit more with open procedures. But the resident tends to have a lot more endovascular swagger because they've been doing endovascular procedures since they were an intern. By the end of their training, they pretty much have equivalent vascular skills. The only caveat for that is that you need to go to a program that's got sufficient open and endovascular experiences, like St. Louis University or Case or University of Michigan. These are all good programs to go and get fully trained. My other gestalt is if you're thinking about geography, it might matter a little bit more to you because vascular surgery integrated residency is a tough match some years. And so if you really are tied to a certain area and you have to be in that area, you might have more success going general surgery. And then also if you're unsure, obviously you should go into general surgery. If you're unsure if you want to do vascular surgery, but you know you want to do a surgical field, by all means, you should go into general surgery. You can still get into vascular from general surgery. Finally, I think there's a lot of benefit for programs that have fellowships and residency. This is a picture taken last year. He's now our 2nd year fellow, but that was our 1st year fellow being taken through a case by our 5th year resident. So there's a lot of opportunity for fellows to learn from residents and vice versa, depending on the case. So just to show you some more stats, these are stats from last year. I didn't update this for this year's stats. I apologize. But they're kind of similar. There's around 65 programs, around 80 spots for the integrated vascular residency. Last year, there was 181 total applicants. There was about a 70% vascular match rate if you had an MD, and there was about a 23% vascular match rate if you were a DO. If you look at vascular surgery fellowship, there's about 103 spots at 118 spots at 94 programs, and they had a pretty good match rate, no unfilled spots, and a little bit maybe less competitive match for the fellowship. If you look at the integrated residency scores here, it's not really rocket science, but what this table shows you that the higher your USMLE score, the more likely you were to match. This one shows you that if you only ranked vascular programs, you had a slightly higher rate of matching, but that's kind of skewed data because maybe if you were unsure if you were going to match, you might have applied to more programs. You might not have been as competitive as a applicant. And then this table on the bottom shows you that the people who ranked more programs were more likely to match. In fact, that most people ranked 16 or more programs, which is another discussion. That's an exceedingly high number. In closing, I just want to point out that, vascular surgery is a great field to get into as far as job security goes. Dr. Wong already mentioned this, but, projected over, the next several years, all these diseases are diseases that are treated by vascular surgeons, and we're kind of in the highest demand bracket here as far as needed specialties. Can you have a life as a vascular surgeon? You can. I'm an academic surgeon. I have maybe 6 to 10 cases per week. I do clinic 1 day a week. I do research, write papers, go to conferences. Also spend a lot of time teaching, call 1 day a week, call 1 week in a month. I've got 3 kids. I make it home for dinner most nights. I was present at all my children's birth. So you can have a life if you really want it to be. So don't let that discourage you from going into a surgical field. In summary, vascular surgeons are needed. I think both integrated and vascular surgery fellowships are viable options for training. And I think that either way, you can get to the spot that you want to go to. I'd be happy to take any questions either now or feel free to send me an email. And that's about it.
All right, thank you, Dr. Smeds. That was a pretty good overview of kind of everything that's new and old about how to become a vascular surgeon. For our final talk today, we have Dr. Rouse, who's from Cleveland Clinic in Cleveland, Ohio. And he's going to talk to us about how to find a mentor and how to use them to kind of get what you need from them to kind of figure out whether you want to do vascular surgery and how to get into vascular surgery.
Thanks for the introduction. Yeah, I think I'll try to keep it as brief as possible because I think a lot of the speakers today, pretty much all of the speakers today have highlighted how important mentors have been, not only in their decision to become a vascular surgeon, but their progress and progression through the specialty and career in their careers. So, I think this is for me, this is how I got into vascular surgery and what inspired me to become a vascular surgeon. And I'll touch on that a little bit here in a second. But basically, a mentor is someone who sees your talent and then basically helps bring it out in you. And I think that's really where it comes into. You find someone that finds you, that is inspired by you as a person, that finds someone that you're interested in, that both you find that connection, and then you can basically from there both help each other along the way. Because I've definitely been inspired by other people to become better and improve myself as well. A mentor is essentially an experienced and trusted advisor. So there's lots of things that go into this. It can be the relationship, it can be the person, it can be a research project, it can be a short time that you're spending with this person, but it doesn't have to be a lifelong process that happens here. But it's someone that you both can get something out of. And I think a mentor can get just as much out of the relationship as a mentee. We all need someone who inspires us again. And I think, like I said before, we are all a result of a great mentoring, and that's how we all ended up here. So I think really the 3 A's that people always talk about, not only how to become a good surgeon or doctor or a good consultant, the 3 A's also apply to being a mentor: available, affable, and able. So available, what does that mean? You've got to have access to the mentor. You can't have a mentor who's like, I'll meet with you in 6 months. You got to have someone that will sit down and meet with you on a regular basis, or be open to meeting with you. Hey, let's grab a cup of coffee. Let's just meet in the hall. Let's chat. I'm having this issue, or whatever it may be, or you're working on a research project or some other, whatever the interaction may be. You got to be able to get to that person. And I think the other issue, the other thing that comes into it is a lot of times we're afraid to ask. Surgeons are busy. We're busy. Lots of people have lots of obligations, but we're afraid to ask, hey, can you spare me 5 minutes? It doesn't always have to be a large amount of time. It can be a small amount of time that really allows you to get that face-to-face interaction and build a relationship with the person. Affable. So obviously you want someone that's pleasant and nice and easy to get along with. You don't want the person who has the reputation of, throwing people out of the operating room, screaming at people, all the outpatient clinical staff, talks bad about. That's not the person you want to try to get, aligned with. And able. So you need someone who's able to help you. Not only are they in a position where you want to be. So I think often we say, Is this the person that I want to be in 10 years, 15 years, whatever the timeline may be? And that's the kind of person you want to find. So like, I think that those are the ones that say, okay, in 15 years, I'd like to be where Dr. Coleman is. I want to be like she is. I want to be have a family, maybe not with the storm, but also, be at somewhere where, she's doing the things that I want to do and I want to be like her. And I think that's really where the ability comes in. What does all this mean? I think really, and so for me, I think that this will just kind of highlight some of the points, but a little bit of my journey along the way. I always wanted to go to college. I wanted to be a surgeon. No one in my family was surgeons. These are my grandparents, and they were big supporters of me. And so I think that's really what inspired me first was they, no matter what I wanted to do, they were always there supporting me, and they were always a sounding board and continuing to encourage me to be better for myself. And so particularly my grandfather was really a big part of that journey along the way. When I got to medical school, I would point out two people, honestly, that really inspired me to go into vascular surgery, and particularly at the Cleveland Clinic where I ended up doing my training. Dr. Nguyen was a transplant surgeon who sort of along the way learned to do vascular surgery. He did AV fistulas and he did bypasses and lots of open surgery. And he was the program director of general surgery residency. We didn't have a strong vascular community where we did lots of advanced endovascular stuff where I went to medical school, but I knew I loved what they were doing. And at the time, Dr. Hardy was there as a general surgery resident, and he had matched to do his fellowship, the 5+2 program at the Cleveland Clinic. And it's honestly how I was recruited basically from Georgia, where I grew up, to Cleveland and where I still am today. But I owe a lot of that to him because he kind of paved that route for me and was a big supporter of me and what I was interested in. Throughout residency, I'll point out three folks that really, I think, impacted me: Dr. Caputo, Dr. Claire, and Leiden, who really were people who took me under their wing, showed me the way to do things, and I really just connected with them throughout the years. And not only started as a residency, but then it became part of my career as I stayed on its staff at the Cleveland Clinic, and still work with two of these guys, regularly. So I think it's really about finding those people that you connect with and really utilizing them, not only in a way that benefits you, but benefits others, or benefits yourself as well. And I think they get something out of it. I don't know, maybe they don't, but I think a lot of them pour into you because there is something to that, building a relationship with each other. The other thing I'll point out is, it's okay to move on. Like I just pointed out during my journey, I've had several people that have come and kind of gone. It's okay to to have a mentor for the right time. Like these folks inspired me to go into vascular surgery, and then I was, I'm still close with them and still talk to them, but I'm not as close to them as I was when I was a medical student. It's okay to have that and still be have a connection with people as you move on. The other thing is be a good mentee. Don't be someone that you forget about, and don't think that that we're always going to be the only ones giving. You got to give too. It's a give and a take. It's about building a relationship with someone. And obviously when it works, it works. And that's pretty much all I got to say about being a mentor. So, but I do think, it's one of the most important reasons for all of us to end up in vascular surgery and how we get to where we are today.
All right, thank you, Dr. Rouse. I think all of us, I can remember at least 2 or 3 people that kind of helped forge who we are today. And so it's very important to both be a mentee and to pay it forward and be a mentor when you get to that level. So I'm going to open it up real quickly for some questions. Currently, we have 1 question. That there's 3 different ways that you can submit a question. One is through the question and answer function in Zoom. The other way is through the chat box, and also you can raise your hand through Zoom as well, and I can kind of keep an eye on all of them. The first question that we have is, what is a good way to tell if a program has sufficient open and endovascular case numbers? I guess, Dr. Rouse, you're probably maybe the closest to this, so maybe you might be able to answer this and how you chose to go to the residency that you did.
Yeah, no, I mean, honestly, once you get to the point where either you're doing an away rotation or you're interviewing with someone, I mean, at least when we have interviews for our program, We have you meet with the senior residents and or fellows, sometimes both. And, you know, you can ask them what their numbers are. You can ask for the case logs of people who are graduating, and most programs will give you those on the interview day. So, I mean, you'll know like how many operations people are graduating with, is particularly if you ask.
Thank you, Dr. Rouse. Is there anyone else who wants to kind of chime in? If there's anything different from the panelists?
There are certainly some programs that will publish case information on their websites. I know there's a lot of social media groups or chat groups among current vascular surgery trainees, or even among vascular surgery interest groups, which are based at many medical schools, that you may hear or be able to find out, you know, how is your case experience? This information is, of course, all something that is known by programs and by trainees themselves, because we all have to keep logs of how many cases and what types of cases our trainees are doing. So the information is definitely out there. It's just a matter of speaking to residents in programs. You can speak to faculty in programs. You can ask at student fairs. There's lots of ways to sort of find out which programs have really good experiences, open, endo, and both, and maybe what percentages too. Thanks.
All right, we have one more, another question. What characters do you look at? What characteristics do you look at in applicants through ERAS when considering who to interview?
I can take that one at least to start, because we've really changed how we look at the ERAS application. And I will say that historically, there were kind of firm metrics that could be really easily filtered. And so honestly, for many, many years, applications would be screened by our program coordinator, and there would be, you know, clear metrics for this filtering process that would, you know, bring in a group that would immediately get an interview, and then there would be a group that didn't get interviews, and then there would be this in-between group, and I would review all of those applications very carefully. And for many, many years now, that process has looked very, very different. And I'll suggest that there are certain ERAS features and characteristics that we no longer pay any attention to, because I think it allows for the introduction of substantial bias. And so we've moved away from that really archaic and probably really limited poor process to one that involves a holistic review of everybody. Now, vascular recruitment's smaller than the scale perhaps of general surgery. So it's still feasible for me as a program director to review every application. And that's what I do. I review every single application myself. For other larger programs, yes. For other larger programs, I think there is now, and we do it for general surgery locally, a recruitment committee in which you've got now a team of people who get trained with a different lens towards eradicating implicit biases and thinking carefully about letters of recommendation. And so you'll have different teams or groups that are reviewing all of the applications. And usually there's kind of a standardized scoring rubric. There's a supplemental application that's utilized right now for general surgery in some programs, but not for vascular, that allows for a little bit of signaling, and that may or may not introduce some consideration to programs that are considering candidates. But I'd propose that more than ever now, especially absent a step 1 score, and thinking about how to look for potential and really be attentive to onboarding and recruiting lots of diverse talent. We've moved to putting far more emphasis on metrics that capture the things that I talked about in my slides earlier. So I'm really looking for service. I'm looking for language in personal statements that suggest candidates are really authentically interested in the specialty. that they do have an academic or kind of a legacy vision that they're looking for a program to help them create. We make no mistake of sharing that we're training future leaders in academic vascular surgery at Michigan. And so it's a big investment to onboard somebody and kind of invest all of those resources. So we're looking for surrogates there. But even at this level, it's impossible to predict who'll be successful, because the fact of the matter is the applicant pool is really talented. And I think most people will thrive in a setting where they're going to have a lot of resources thrust at them. And so at the end of the day, we're looking for individuals who are going to work hard and be really honest, that have had kind of compelling stories of failure with subsequent resilience and grit, team forging capacities, interdisciplinary and kind of communication skills and emotional intelligence that are really high. And I think there are surrogates for this across the application profile, but it's a really different process than it once was.
Thank you, Dr. Coleman. It looks like we have 3 more questions to go. One of them is, will interviews be virtual? What is your advice for the virtual interview setting to get to know residents and a program well? Dr. Wong, do you want to take this one? Or
I was just going to say, Don, I think this one's yours.
The APDVS just posted some guidance yesterday on recruitment this year, and I'll suggest that in alignment with larger kind of credentialing and oversight bodies that are really committed to the learner and the candidates in this process, there's really strong language compelling program directors to consider a virtual interview platform. And I would suggest that the APDVS issues committee and then the council, many of whom are really pro in-person interviews. You have to understand how desperately we all want to bring you to our hospitals and meet you and show you our town and showcase our residents and our fellows. We really want that in person, but there's really good and compelling data to support that this does truly level the playing field to avoid limiting candidates from opportunities. And so if we're going to be committed and intentional about keeping a lens towards diversity in the recruitment process, and I'll tell you, the University of Michigan issued language that part of the virtual interview was to minimize our carbon footprint. I don't think it's any more about COVID, but there are a lot of other reasons to think about it. We've had 4 very successful consecutive matches with this platform. And what we have learned is that there are unmatched candidates now, not unmatched programs. And so I sense that there will probably be a combination of in-person and virtual interview opportunities for all of you this year. And it's gonna feel really interesting for everybody. I think everybody's still kind of navigating that and feeling that out, but I do think you'll feel a combination of things. And there may be some really kind of novel opportunities for programs and trainees this year if things can move forward in the way we hope. And I'll just leave it at that.
There's one more question, I think, to Dr. Smeds here. Any questions on why DO match rates are so poor?
Yeah, no, that's a good question. You know, there might be some bias in programs. It might be the applicants themselves choosing, you know, where to apply and what programs to apply to. I don't really know. We have a DO fellow in our program. We also have a DO integrated resident. I really see no difference in DO versus MD. It's not something that I particularly look at when I'm reviewing applicants. I think the DOs might have a slightly less exposure to vascular surgery. And so I think a lot of them have decreased opportunities to get involved with vascular research and complex vascular care in some of the smaller DO programs. And so that might be contributing to it, but it's a loaded question. But if you're a DO, send your application to SLU. We'll definitely take a look at it. We love you.
All right. Well, I think that kind of ends our session today, at least for the virtual what is vascular surgery and how do I get into it. We are following this with the residency fair, And I think Dr. Smeds can probably just give us a little overview of how this program is going to kind of set up and what we need to do.
Yeah, I'll be real brief here. This is just like a real, residency fair where there's a bunch of tables sitting around and you went up to whatever tables you were interested in. So you should have all received a list of the links for the individual programs' Zoom rooms, and just go to whatever programs you're interested in meeting people at. Stay for as long as you want, and each of those programs will tell you whatever they want, and they'll have their room structured, in whatever ways they want. So make sure you visit everybody. This is your opportunity to meet program directors, trainees, other faculty, and I think it's just a good opportunity to kind of meet people in the vascular world. I think we're all quite friendly and be happy to chat with you. So that's about it. If you don't have the links, send a message to Angela on the Zoom here, or myself, and we can send you the links.
All right. Well, I guess that ends our time today. There is another medical student event at the in-person MVSS meeting in September. It's for kind of skills session where we're going to go over suturing and different surgical skills that are kind of commensurate for most students, and also to kind of talk about what we do as vascular surgeons in a kind of open and endovascular fashion. So if you're interested and you're able to come to Grand Rapids this year, please do, and register for it. There's also scholarships available to help kind of defray some of the costs for travel and things like that. From the MVSS, we wanted to thank everyone for participating today, and then have fun at the residency fair.